evening. Good evening, everyone. I welcome you all for this Neurosciences Forum CME, which is jointly being conducted along with the Indian Medical Association, Coimbatore AMS. This meeting every month we are conducting, and with the different topics and different speakers in that particular field, so that the IMA Coimbatore people and even all IMA doctors are benefited by joining this program. So that is the main aim of joining a program with this IMA. And every month, based on the national and international days which are coming, we used to conduct the program. Actually, this program which we scheduled today was actually the program of the month of December. In December, we used to have the World AIDS Day and World Rehabilitation Day. So that's why the topics are the AIDS and the thing. So I request all of you to please enter your in the chat box your name, your email ID, your WhatsApp number, and your Tamil Nadu Medical Council registration number, so that to get the credit hours, it will be useful for us to do it. And coming to today's meeting, one topic will be covered by Dr. Sacratis, the neurophysician, who is going to talk about the HIV. And another talk by Dr. Balamurali, who is very much interested in, he is mainly the neurosurgeon specialized with spine surgery. He is very much interested in doing the rehabilitation work. So this meeting will be of much use to most of the people. And I invite Dr. Sacratis and Dr. Balamurali sir to join the program. I welcome you, sir, for obliging us and planning to give the talk, even with the busy schedule.
Thank you, sir.
Thank
Now,
you.
before introduction about the Socrates, I invite Dr. Sitharaman sir to tell a few points about this meet. Dr. Sitharaman sir.
Sir, good evening, sir. Dr. Sitaram, sir, Secretary, Coimbatore Branch, sir. Sir, Rajesh Babu, sir, usually is, he used to conduct a lot of meetings, sir. And I'm happy to be part of this neuroscience forum also. And this meet is important because it gives awareness of patients with HIV and the neuroscience forum also. So I asked sir to continue the meeting, sir, and we'll be joining behind, sir. Thank you for the invite, sir.
So now the first speaker will be Dr. Socrates. Professor Dr. Socratis is completed his MBBS from Coimbatore Medical College and MD General Medicine from Coimbatore Medical College and DM from Institute of Neurology, Chennai. And currently he is working as he was previously posted Institute of Mental Health in 2002 to 2004 and employment abroad between 2004 to 2006. And then presently he is the associate professor of the assistant professor of the Government Medical College, Coimbatore. Now presently associate professor in the neurology department in Coimbatore Medical College. Published papers and case reports, speaker and chairpersons in CanCon, and promoter and transfer to Government KAP Medical College, Salem. And his areas of interest are headache, stroke, epilepsy, and neuromuscular disorder. Today he is going to talk about the HIV, neurophysician's role in HIV. I welcome you, sir.
Thank you, sir. So I'm here to talk about role of neurophysician in HIV. So neurologist has 4 roles to play. One is diagnostic role, therapeutic role, preventive role, and research and education role. In diagnostic role, the main thing is diagnosing HIV-associated neurocognitive disorder. Associated neurocognitive disorder, and in identifying the opportunistic infections and detecting the neurological complications arising out of HIV itself and the treatment. So what are the therapeutic roles? Neurologists assist in antiretroviral therapy management and treatment of opportunistic infections and pain management arising due to neuropathy and other causes. Preventive role, they advise on CNS prophylaxis to prevent opportunistic infections in HIV patients. They advise also vaccine recommendations to prevent pneumococcal and meningococcal meningitis. So research and education role. So they participate in clinical trials to develop new treatments for HIV-related neurological disorders. And also they educate the healthcare providers, patients, and caregivers regarding the HIV itself and its manifestations and complications. So introduction, HIV is a lentivirus, is part of a retroviridae family. And what are the effects it can cause? Immunodeficiency, neoplasia, and neurological disease. So what's the pathogenesis? So 3 steps: neuroinvasive, neurotropic, and neurovirulent. What is neuroinvasive? The ability of the virus to enter the central nervous system. What is neurotropic? The ability of the virus to survive in the nervous system. And what is neurovirulent? The ability of the organism to produce disease in the nervous system. So how does it affect the nervous system? By direct and indirect effects. So direct effect is by the HIV virus itself and its products, and indirect is by the opportunistic infections and HIV associated neoplasms. So the cells affected by HIV virus are perivascular macrophages, monocytes from the blood, microglial cells, but the neurons and oligodendrocytes are rarely involved. So when you classify the involvement of the CNS and PNS due to HIV virus, so if you see this picture, the brain, meninges, spinal cord, peripheral nerves, and muscles. So it can affect all the things. So in the brain, it can cause dementia, space-occupying lesions, encephalitis, stroke-like syndromes, meninges, meningitis, spinal cord, myelopathy, radiculopathy, peripheral nerves, peripheral neuropathy, inflammatory demyelinating neuropathy, toxic neuropathy, and in muscles, polymyositis, pyomyositis, and HIV wasting syndrome. So in dementia, the pathology involved may be HIV encephalopathy or AIDS dementia complex, progressive multifocal leukoencephalopathy, and tuberculosis. The things mentioned in the red are AIDS defining illnesses. See, other causes, less common causes, are neurosyphilis and lymphoma. So they can present as a space occupying lesion also. So they can be abscesses, infective granulomas, neoplastic, and other things. So another thing is encephalitis. So cytomegalovirus, progressive multifocal leukoencephalopathy, herpes simplex virus, toxoplasma, and fungi produce encephalitis-like picture. And AIDS patient presenting with stroke-like syndromes. So this could be due to granulomatous angiitis, AIDS associated, or infective vasculitis, tuberculosis neurosyphilis, aspergillus, and varicella zoster virus vasculitis, bacterial endocarditis, venous thrombosis, DIC, and metabolic coagulopathy, metastatic. And meningitis. Meningitis could be acute and chronic. So acute meningitis occurs during seroconversion, aseptic meningitis. The usual organisms are pneumococcal, meningococcal, E. coli, and Klebsiella. And the chronic due to Mycobacterium tuberculosis, Mycobacterium avium complex, and Cryptococcus. These define the AIDS defining complex. And the early HIV infection is characterized by seroconversion. 40 to 90% of patients undergo seroconversion. It is manifested by flu-like or mononucleosis-like symptoms, fever, lymphadenopathy, night sweats, rash, headache, and most of the patients remain asymptomatic. The CSF and imaging in the early infection may be abnormal even during the asymptomatic period. They are suggestive of later neurological events. Only minority of patients present with aseptic meningitis, Bell's palsy, neuropathy, etc. But the neurological symptoms may precede the HIV positivity, ELISA positivity. So ELISA negative does not rule out the neurological symptoms. So the typical relationship of clinical manifestations to CD4 count in HIV infected patients are seroconversion and or CD4 count more than 500. They can manifest with meningitis, meningoencephalitis, Bell's palsy, Guillain-Barré syndrome, brachial neuritis, transverse myelitis. The CD4 count is between 200 and 500. Tuberculous meningitis, Guillain-Barré syndrome, distal sensory polyneuropathy, polymyositis, and minor neurocognitive disorder. And if the CD4 count is less than 200, they have AIDS-associated dementia, TB meningitis, cryptococcal meningitis, toxoplasmosis, progressive multifocal leukoencephalopathy, primary CNS lymphoma, nocardia brain abscess, distal sensory polyneuropathy, vascular myelopathy, cytomegalovirus meningitis, ischemic CVA, and radiculopathy. So early HIV infection, if you check the CSF, might show lymphocytic pleocytosis, normal or slightly elevated protein, and normal glucose. Most of the patients recover. A few might have recurrent bouts. So we should do the Western blot or PCR to confirm the HIV in the early neurological symptoms. So what are the HIV-associated neurological syndromes? So they classify into primary HIV neurological syndrome, secondary HIV neurological syndrome, and treatment-related neurological disease. So what are the primary HIV neurological syndromes? Aseptic meningitis or meningoencephalitis, HIV-associated neurocognitive disorders, HIV-associated vascular myelopathy, HIV-associated peripheral neuropathy, and progressive multifocal leukoencephalopathy. So the aseptic meningitis is the most common neurologic syndrome associated with primary HIV infection. So symptoms are fever, headache, stiffness, and photophobia. Treatment is symptomatic. Most patients recover. So the next most common is the HIV-associated neurocognitive disorder. It manifests in 3 stages. Stage 1 is asymptomatic neurocognitive impairment, ANI, and stage 2 is minor neurocognitive disorder, MND, and stage 3 had HIV-associated dementia. So in asymptomatic neurocognitive impairment, they have subclinical decline in the cognitive impairment, which is identified in detailed neuropsychological evaluation only, not in routine life. In MND, minor neurocognitive disorder, there's a mild decline in cognition in addition to everyday functional impairment in the most difficult activities of the daily living. In the HAD, that is HIV-associated dementia, significant decline in cognition even with daily activities of living. So the diagnosis of HAND is made after ruling out all the confounding conditions like opportunistic infections, neurosyphilis, substance abuse, delirium, toxic metabolic disorders, psychotic disease, and age-related other dementias must be ruled out before confirming HAND. Most commonly affected domains in the hand are the attention concentration, psychomotor speed, memory and learning, information processing, and executive function. The language and visual spatial functions are not affected. The hand is characterized by subcortical dementia, that is, the memory is improved by cueing. So there is profound effects on the pyramidal and extrapyramidal systems. Milder symptoms like ataxia, motor slowing, incoordination, and tremors may be seen. They may progress to severe disabling weakness, paraparesis, spasticity, and movement disorders. So they can also manifest as behavioral disorders like apathy, irritability, and psychomotor retardation, so which can be mistaken for depression. So AIDS patient develop manic symptoms, which may be a symptom of pre-existing bipolar disorder or may be a reaction to the drug, referred to as secondary or AIDS mania. So the brain in the hand may appear grossly normal in imaging until advanced stage. So the MRI features are ventricular enlargement, atrophy of the caudate, putamen, nucleus accumbens, and other subcortical regions that may characterize hand. And the MRS shows reduced N-acetyl aspartate and increased myoinositol in the basal ganglia and frontal white matter. These changes are not seen in the parietal region, which is seen in the other dementias. And FTG PET shows early hypermetabolism and in the basal ganglia and followed by hypometabolism in the late hand. In Alzheimer's and other dementias, the hypometabolism is the presentation right from the beginning, gradually progressing. Only here you have initial hypermetabolism followed by hypometabolism. So the neurological and neuropsychological symptoms improved after antiretroviral therapy. So zidovudine monotherapy studies revealed that's improved in neuropsychological scores. So the current treatment of HIV is based on the use of combination ART that includes 2 or more antiretroviral agents to suppress the HIV load and to increase the CD4 counts. The most common initial combination ART regimens are 2 nucleoside or 2 nucleotide reverse transcript inhibitors combined with either a non-nucleoside reverse transcriptase inhibitor or a protease inhibitor. So protease inhibitor will act as a booster. So it enhances the other protease inhibitors so that they can be given at lower doses. So the placebo control trials are not carried out in hand because of the ethical issues. So based on well-controlled studies, it appears the combination ART improves neuropsychological performance in hand syndrome. It also appears that so the combination ART has reduced the new cases of severe hand, while apparently it is increasing the number of and lifespan of individuals with milder forms of hand. So next syndrome is the HIV-associated vascular myelopathy, the most common spinal cord disease of age. It's a slowly progressive leg weakness, spasticity and posterior column involvement, vibration and position sense affected, atoxic gait and urinary frequency and urgency. So erectile dysfunction may be an early sign in men. So they may present with paresthesias of legs with neuropathic pain, hyperreflexia and extensor plantar responses. In advanced cases, patient may become wheelchair bound and doubly incontinent. So the diagnosis should be questioned when the presentation is acute patient or the arms are affected and there is a sensory level, or if there is a back pain, you should reconsider the HIV-associated myelopathy diagnosis. So HIV-associated myelopathy neuroimaging features, in many cases the MRI is normal. Some cases may reveal high signal hyperintense areas in T2-weighted imaging, primarily in the dorsal region, affecting the posterior column that coincide with the areas of vacuolation on histopathology. So there are some case reports of improvement following the combination ART. So next syndrome is HIV-associated peripheral neuropathies. So they are different types: HIV-associated distal sensory polyneuropathy, neurotoxic nucleoside-induced neuropathy, inflammatory demyelinating neuropathy, radiculopathy, mononeuropathy, and mononeuritis multiplex. So what's the pathogenesis of HIV neuropathy? So there are 2 distinct processes: neurotoxic effects of the HIV itself and neurotoxic effects of the antiretroviral therapy. So the mechanism is mitochondrial toxicity. So that lead to distal axonal degeneration, neuronal loss in the dorsal root ganglion, reduced epidermal fiber density. So the next syndrome is distal sensory polyneuropathy. They present with painful feet, hyperpathia localized to the feet alone. Weakness is usually mild or absent.
Usha patient.
Yes? Hello. Neurologic examination reveals the absent ankle joints. In 96 to 100% of cases, the sensations of pain and temperature are impaired in distal portion of the legs in 80%. So the electrophysiological findings, small or absent sural nerve conduction potentials, they usually conform a length-dependent polyneuropathy. So what's the treatment? Symptomatic treatment of foot pain using non-steroidal anti-inflammatory drugs, topical analgesics, lidocaine and capsaicin, tricyclic antidepressants. and anti-epileptic agents and narcotic analgesics. So toxic neuropathy from antiretroviral drugs. So with the advent of highly active antiretroviral therapy, the incidence of distal sensory polyneuropathy has increased largely because of the use of non-nucleoside reverse transcriptase inhibitors like diadenosine, zalcitabine, and staudin. So the toxic effects of NRTI is dose dependent and is estimated to 15 to 30% of those receiving the drugs. So, what is the treatment of neurotoxic neuropathy? So the management of antiretroviral induced neuropathy, excluding the potential causes. So, the other causes of neuropathy, like vitamin B12 deficiency, chronic alcoholism, uremia, diabetes mellitus, may be coexistent in HIV. So, that should be ruled out before confirming the further management options include removal of the putative causative drug and symptomatic treatment using the pain relief medications. So, inflammatory demyelinating polyneuropathies, they can be acute or chronic. So, few cases have occurred during the immune reconstitution syndrome. So, the electrophysiological studies show patchy distribution of abnormalities, slow or absent nerve conduction, and abnormal FBS. So, the treatment consists of supportive intravenous immunoglobulin, plasma exchange, and possibly combination ART. So, chronic inflammatory demyelinating polyneuropathy can occur in late infection and is often associated with CD4 count of 50 or below. So, the progress slowly, they may have relapsing and remitting course, and it must be differentiated from other neuropathies caused by cytomegalovirus and related viruses. So, the treatment is similar to that of other CIDPs, non-HIV related CIDPs, immunoglobulin and steroids. So, diffuse inflammatory lymphocytosis syndrome. This is characterized by persistent peripheral polyclonal CD8 lymphocytosis and by visceral CD8 T cell infiltration involving the salivary glands, lungs, kidneys, gastrointestinal tract, and peripheral nerves. So, clinically, the distal diffuse infiltrative lymphocytosis syndrome presents as acute or subacute, painful, multifocal, most often symmetrical neuropathy. So, the treatment primarily antiretroviral therapy or the corticosteroids. So next is HIV-associated neuromuscular weakness syndrome, characterized by hyperlactatemia, nausea, vomiting, hepatomegaly, progressive muscle weakness. It is described in association with NRTI treatment, nucleoside reverse transcriptase inhibitor. Motor weakness develops rapidly over days or weeks and evolves in some cases into respiratory failure and death, mimicking a Guillain-Barré syndrome. This should be recognized. And HIV associated neuromuscular weakness syndrome, the mortality rate is 13%. So the pathophysiologic mechanism is mitochondrial toxicity of prolonged use of NRTA. So next is progressive multifocal encephalopathy, is a central demyelinating disease resulting from reactivation of a latent infection of the oligodendrocytes by the JC polyomavirus. Right? It is subacute onset of altered mental status accompanied by focal symptoms, hemiplegia, hemiparesis, hemianopsia, ataxia, vertigo, according to the region of involvement with one or more PML lesions. So patients usually do not have headache, fever, nausea, vomiting, or papilledema. So the neuroimaging, they may show one or more space-occurring white matter lesions that are non-enhancing, hyperintense on T2 and hypointense on T1, and they spare the cortical U fibers. Some cases do enhance, that may be a better prognostic factor. So we have a T1 hypointensity and T2 hyperintensity. This paradoxical region. And CSF in progressive multifocal encephalopathy. So this is primarily to rule out other causes of CNS infections, and non-specific mild pleocytosis, elevated total protein and normal glucose, and positive JC virus PCR. So what's the treatment? There's no specific treatment, but ART has improved the course of AIDS PML, decreasing the mortality rate, improving the neuroimaging features, and improving the survival, and decreasing the JC virus load also. So next one is immune reconstitution inflammatory syndrome. So this refers to group of syndromes characterized by paradoxical worsening, clinical worsening that usually occurs 4 to 8 weeks after starting combination antiretroviral therapy. So the reconstituted immune system generates an inflammatory response that results in either worsening of a known or underlying infection or unmasking of a subclinical or indolent infection. So this is characterized by massive infiltration of CD8 cells. So what are the risk factors for developing IRIS, immune reconstitution inflammatory syndrome? So taking combination ART for first time, active or subclinical opportunistic infection, CD4 counts under 50 cells per cubic millimeter, high CD8 cells, anemia, and rapid decline in HIV viral load. So the most common infections reported to be involved in iris are HIV encephalitis, Toxoplasma encephalitis, cytomegalovirus, and progressive multifocal leukoencephalopathy. So imaging in iris, so there is new development or increase in contrast enhancement, unusual pattern of contrast enhancement. So treatment is corticosteroids. So these are the differential contrast enhancement in iris. So infectious non-focal brain disease. So in PML, the temporal progression is in weeks and the level of alertness is preserved, fever is absent. AIDS dementia complex, it develops over weeks or months, the level of alertness is preserved, fever is absent. In cytomegalovirus encephalitis, progresses over days to weeks, reduced level of alertness and fever is common. So the progression, temporal course, and level of alertness and presence of fever helps us to differentiate between this. So what are the secondary HIV-associated neurological disorders? These are nothing but opportunistic infection. So the impact of heart on the incidence of opportunistic infections. So from 1992 until 1997, there is a severe decline in incidence of opportunistic infections after the effect of highly active antiretroviral therapy. So this is the incidence of opportunistic infections. So TB is the highest one, followed by Candida and Cryptococcal diarrhea, and then Herpes zoster, Toxoplasmosis. So this is the CD4 count and the relevant infections. So the most common it's defining as cerebral toxoplasmosis among the opportunistic infections and is also most treatable. It results from latent activation of the Toxoplasma gondii. So headache, fever, confusion, personality change, and focal neurological deficit. So acute onset of these could suggest toxoplasmosis with the background of HIV. And imaging shows multiple lesions 1 to 4 centimeters in the corticomedullary junction and basal ganglia. Lesions show ring or nodular enhancement with associated edema and mass effect. They can also hemorrhage. So the enhancement is diminished or absent in severely immunocompromised patients. So the differential diagnosis for this CNS lymphoma, which appear identical and can coexist in the same patient with toxoplasmosis. So this is cerebral toxoplasmosis presenting as a mass lesion involving the basal ganglia and corticomedullary junction. So this is a coexisting toxoplasmosis and lymphoma. So involving the basal ganglia. Imaging features. So in comparison to the cerebral toxoplasmosis is hypointense in white matter in DWI, indicating no restriction diffusion. In MRS, elevated lipid lactate peaks may be seen. So treatment is with pyrimethamine and sulfadiazine. So most lesions show reduced enhancement, edema mass effect within 2 to 4 weeks of treatment. Enhancement is so enhancement is typical in the nodular ring enhancing ring surrounding a zonal of central necrosis. The primary cerebral lymphoma, it is the age-defining disease in 5% of patients. So the incidence has reduced following the HART, highly active antiretroviral therapy. Patient present with rapid progression of confusion, lethargy, and memory loss, and focal neurology. Here, fever is absent. So lymphoma can be multifocal also. So it involves the supratentorial and infratentorial also, peritrigonal region and basal ganglia, and also in the cerebellum. So how to differentiate lymphoma versus toxoplasmosis? Single enhancing mass lesion likely to be lymphoma, and subependymal spread is a feature of lymphoma. So thallium SPECT and FTG PET, a greater uptake in lymphoma than toxoplasmosis. So primary versus secondary lymphoma. So metastasis from systemic lymphoma typically involve the meninges, parenchymal disease, without the leptomeningeal involvement. So the treatment of primary cerebral lymphoma is radiotherapy or corticosteroids. HART has prolonged the survival in 2 to 8 months. So next, second commonest is the cryptococcal infection. So most patients present with headache, fever, and altered mental status. The earliest neurological imaging finding is dilatation of perivascular spaces due to mucoid material organisms or inflammatory cells, and appears multiple small foci of high signal on T2-weighted image. So it spreads to the CNS to hematological spread from the pulmonary focus. So reactivation of latent infection within the CNS also possible. So with the disease progression, it can develop at different sites, forming 3 millimeters to several centimeters in size, most often in the basal ganglia, but also in the brainstem and cerebral white matter. So the enhancement of leptomeninges is rare. So as they are profoundly immunocompromised, that CD4 count is less than 50. So here you can see in the midbrain there is a hyperintense lesion, and in the basal ganglia in the middle picture, and hyperintense on T1. So the next common infection is tuberculosis. CNS tuberculosis is an AIDS-defining illness. Initial manifestation of the AIDS may be. So it can result from a reactivation of previous infection or spread from the pulmonary infection, mainly hematogenous. So 5 to 9% of patients, and 2% of 2 to 18% will have CNS infection. All tuberculosis patients. So have a high mortality rate of 70%. Chest X-ray is positive in only 65%. So the imaging shows tuberculosis hypointense early stage. As they mature, they develop hypointense center surrounded by isointense capsule, which corresponds to solid caseation necrosis. So they may further progress to abscess formation with hyperintense center. So a tuberculoma presenting with hyperintensity may progress to abscess. Post-contrast images, granuloma shows nodular homogeneous enhancement, non-caseating, and ring enhancement, caseating. So this is the meningitis, basal meninges enhanced. So the treatment is antituberculous treatment. And the next one is herpes virus. So the herpes virus, herpes simplex virus, cytomegalovirus, herpes zoster virus can cause similar picture, encephalitis, necrotizing ventriculitis, and myelitis also in AIDS patients. So in encephalitis, the imaging may be normal, but may show non-specific white matter changes or focal enhancing lesions, but usually may be normal. So ependymal enhancement occurs in ventriculitis. So myelitis also manifests as a non-specific swelling and signal change in spinal cord. So this is the herpes simplex ventriculitis, enlargement of the ventricle and enhancement of the subependymal region. So next infection is neurosyphilis. CNS involvement can occur in syphilis patient in HIV infection, its course may be more aggressive. The meningovascular syphilis causes small vessel endarteritis that appears as arterial segmental bleeding on angiography with associated infarcts in the basal ganglia. So cerebral gammas are rare, typically arise from meninges. They appear as mass lesions with variable MR signal characteristics and enhancement. So here you can see a meningeal enhancement in the parietal region. So the next infection is mucocutaneous candidiasis. CNS involvement is rare. Hematogenous dissemination results in meningitis or cerebral abscess. So the imaging appearances are non-specific. So clinical confirmation and CSF analysis, brain biopsy. So this 2-minute HIV Neuroscreen. If you see a memory loss, slow mentation, should suspect dementia. And if they present with Cardiac syndrome, cytomegalovirus radiculitis may be a problem. And leg weakness, sensory level myelopathy, and epidural abscess may be a possibility. And ascending paralysis, you should suspect Guillain-Barré syndrome, lactic acidosis. A pain in feet, absent ankle jerk, sensory neuropathy. Seizures, focal deficit, toxoplasmosis. Slowly progressive deficit, progressive multifocal leukoencephalopathy. Cranial neuropathies, intracranial pressure elevation might point cryptococcal meningitis. So this is a criteria for starting, discontinuing, and restarting infection prophylaxis for adults in HIV. So in PCP pneumonia, criteria for initiating primary prophylaxis, if the CD4 count is less than 200 or oral candidiasis. Criteria for discontinuing primary prophylaxis, CD4 more than 200 for more than 3 months. The criteria for restarting primary prophylaxis, CD4 count less than 200. So this is the criteria for toxoplasmosis, Mycobacterium avium complex, cryptococcosis, histoplasmosis, and cytomegalovirus. So take-home message is early diagnosis of HIV infection most important because early detection of neurological syndromes, starting early combination ART therapy, and early prophylaxis for opportunistic infections. So this prevents the opportunistic infections and progression of neurological involvement and complications like stroke and seizures arising out of opportunistic infections or vasculitis problems. So it slows down the progression in hand syndrome and improvement in the neuropsychological performance. So early detection of HIV is more important, and treatment of early opportunistic infections prevents all the complications. Thank you.
The second speaker will be Dr.G.Balamurali, sir, who is very much interested in the spine neurosurgeon, and he is qualified from Bangalore University MBBS and MRCs from Edinburgh and FRCs from Surgical Neurology and Fellow of Royal College of Surgeons, Edinburgh, and MD Research University of Central Lancashire, Preston, UK. Professional summary: internationally trained spine surgeon with 16 years of surgical experience from UK, extensively trained in all key aspects of spinal surgery as part of a 3-year fellowship in UK, Liverpool, Nottingham, USA, San Francisco, Chicago, and Switzerland, Zurich. Senior spine and neurosurgeon in India since 2011. Director, International Spine Academy, Spine. Managing Director, HAMSA Spine and Brain Rehabilitation. Director and Trainer, Get Fit 360. Research and publications interested in academics, research and training, presented around the world in multiple areas of neurological surgery. Peer-reviewed publications 24, national presentation 135, invited lectures 80, live workshops 89, book chapters 8, book 3, and faculty more than 170 conferences. Now I invite Dr. Balamurali sir for this lecture. Welcome you, sir.
Thank you, Dr. Rajesh Babu. First of all, I'd like to congratulate you for, being very active in the academic circles, both of the Tamil Nadu Association of Neurosurgeons as well as IMA. I've known you now for 10 years. I've known you for 10 years. And I think I should first congratulate you for your dedication to, pushing academics in various forums. And thank you for inviting me for this talk. Unfortunately, we were supposed to do in December and I got a little busy. So today I'm going to talk to you about the advances in neuro rehabilitation. What are the opportunities? What's the future? So before that, I just thought that we should understand this very, very important topic, which is actually common for everybody who's a listener today. You may be a neurosurgeon, you may be orthopedic surgeon, you may be a general physician, you may be a pathologist, or you may be anybody here. It is very important as doctors to understand why is rehabilitation so important. And in fact, what is the situation in India compared to the Western world? So, we are the number one in the population in the world. And being the number one, our disease spectrums have also changed over the last 2 decades. So previously, people died of a lower respiratory infection, diarrheal disease, perinatal conditions, but that's changing. And in the 2020s, globally, the shift is from death and disability is from ischemic heart disease, road accidents, cerebrovascular accidents, and all the other infectious diseases are coming down because of better healthcare. And we are in India specifically, we are the biggest contributor to obesity, diabetes, hypertension, stroke, and various other problems. And India is the number one capital for head and road accidents worldwide. Something we're proud about. And usually spine injuries and brain injuries happen either due to a fall or due to road accident. So 95% of the reasons for these are come within these two categories. But why should we worry about this? It's something, very serious, because 75% of the victims are men who are the only breadwinners. So this is just showing that our economy is really going down, because the more people are involved in accidents, they become non-productive and they are not very useful to the society in terms of earning for their family. The second is 90% of them are men at very young age group, 20 to 40. So their productivity in terms of longevity of life is also reducing. So this leads to a tremendous family, social, and economical problem. So this is a problem that our country has to be looking into very, very seriously, which in the last 10 years has changed. I don't want to go into details, but the new government has come with specific targets that rehabilitation should be a part of healthcare in every district government hospital. Every medical college should have a rehabilitation department. This may take another 10 years to be implemented, but I can see that there is a very, very positive change, especially in Tamil Nadu. There is a very good change. So head and spine injury can cause permanent disability. It's probably more dangerous than death itself. Many people, they come and say, he might as well have my family member or a friend or somebody might as well have died, because they are a very big burden to the entire family. And we all know that, we are a land of temples, Tamil Nadu, but how many of you knew that, we are also a land of road accidents? In India, Tamil Nadu especially ranks number one in terms of road accidents. Though we have better highways, we have better facilities, but probably we have very high speed roads. Now, coming to the next most commonest neurological problem that needs rehabilitation is stroke. So we are the third commonest cause of death in India is stroke. It's a major lifestyle disease, and it is more common in the urban population than the rural. And about 55% of people who develop a stroke will have a permanent disability. And we see strokes now in people as young as 25 to 30 due to multiple lifestyle disease. So if you look at the data from WHO, which is very interesting, if you look at, HIV AIDS, what we had discussed from Socrates sir, which he spoke very beautifully, is reducing. The number of cases is reducing by 50%. Diabetes, however, is on the other hand, is increasing significantly, more than 80% between 2020 and 19. Alzheimer's, dementia is almost doubled, but strokes and road accidents have increased by 210 million years lived with disability. So there are two important markers of disability. One is called DALY and one is called as YLD. So these two are important, the disability adjusted life year and years lived with disability. So this is significantly rising. So if you look at life expectancy, globally, the life expectancy has increased. In India, it has increased more because our healthcare system is much better. But health life expectancy has increased by 8%, but the years lived with disability are still not reduced. So this is a serious problem, which means there are people living longer, but they're living with more disability. So if you are living with disability, then somebody has to take care of them. So the healthcare system, unfortunately, in India is not government centric. It is a dual system. So we have private and the government. And unfortunately, that we do not have a standardized system in healthcare, unlike in many other countries. So 85% of our population, live worldwide in underdeveloped countries, and in India, probably similar. And only 10% of them, or I would say even less than 10% of them, have even access to rehabilitation or even know what rehabilitation is. So 1 in 3 people, this is very shocking news, 1 in 3 people will benefit from rehabilitation. Nearly 50% of the world population has some form of disability. And first time in the history, our children will die before us due to obesity and lifestyle disease. This last point is really very shocking. And this is actually data from WHO. And the reason for that, they say, is because of the lifestyle disease that is kind of slowly erupting and causing problems and hospitalizations. And I'm sure all of you would have seen people who had back pain in their 40s now come in their 20s. People who had stroke in their 50s and 60s now come early. Cancer is much more, detected early. So we are seeing that, lifestyle disease is playing a major role. In healthcare, we have excellent healthcare, at least in the southern part of India. In the southern states of India, we have excellent healthcare. And the buzzwords now in healthcare are all about, especially after COVID, is about rehabilitation, it's about wellness, it's about alternative medicine, home care. People want therapy right at their doorstep, transitional care. People don't have family members, nuclear families to take care of the parents. Out of hospital care, if a patient has a stroke or has a major surgery, there's nobody to take care of them when they go home. And this is more so because of our urbanization and our lifestyle. And there is also a lot of healthcare technology advances in AR, artificial intelligence, virtual reality, and all of these things are, slowly coming, and India is going to be one of the largest markets for all of these. So now, in terms of healthcare, we have excellent acute healthcare. If you take Chennai, if you have a stroke, there is at least 150 neurosurgeons in Chennai who can operate on you. But what happens after you have a stroke? If you have, say, a brain surgery or you have a neurological procedure, what happens after? Where do you go? There's not many places. There's probably less than 100 beds in Chennai city where you can have access to rehabilitation. See, rehabilitation doesn't mean that you just occupy a bed in the hospital. And it doesn't mean that one physiotherapist will come and do exercise for you. That is not rehabilitation. So rehabilitation is a science by itself, where you are trying to improve the quality of person, which needs a teamwork, which we will come to. And if you also look at the ratio of specialists to rehab doctors, it's significantly low. Tamil Nadu has only 10 seats for rehabilitation, whereas Tamil Nadu has probably around, I don't know, maybe 30, 40 seats for neurosurgery, about 100 seats for orthopedic surgery. But there is only 10 seats for rehabilitation. The proportion of doctors, specialists who come out with neuro problems is significantly low compared to rehabilitation. So India rehabilitation needs, a lot of unmet needs, lack of, prioritization, lack of available centers, high payout from the pocket. It's very expensive. Lack of trained rehab professionals, not only doctors, even therapists. There's significant, um, very little therapists who have exposure to seeing patients with neurological problems from the physiotherapy, occupational therapy, speech therapy colleges. So the rehab market in India is very big. And the biggest challenge is affordability and reimbursement. Only now rehabilitation is being recognized by insurance companies. Right now, Star Health has introduced, but again, it is not effective. But slowly, I'm sure in the next few years, in a decade to come, insurance will reimburse for rehabilitation. And government also, as I said, has prioritized rehabilitation as an important thing. And if you take in Tamil Nadu, there are at least 10 or 15 district hospitals which have now started a rehabilitation center. And even the WHO have taken 2030 as a big landmark. And there was a recent meeting of all the leaders from worldwide where they have found that worldwide rehabilitation needs to be given more importance than any other healthcare disorder in the last few years. If you look at musculoskeletal studies, so this is published in the Lancet in 2020. They looked at what are the most common musculoskeletal disorders requiring hospital treatment. Number one is back pain and neck pain, and then comes fractures. And if you look at neurological disorders, cerebral palsy, stroke, and traumatic brain injury are the most common reasons which require rehabilitation. And the rise in disability in children as well. There is a significant increase in cerebral palsy, autism, learning disorders, and so many other things which require rehabilitation again. That's another totally different area which we will not touch into today. So why is neurorehabilitation important? After an insult, there is neurological damage, there is severe disability. It can be either complete or incomplete. And the person has to live, they have to survive, the family has to be supported, the person has to become productive, they have to become part of the community, and they have to live and avoid complications. This is the most important thing, is to avoid complications for life. If somebody is going to be in his wheelchair for the rest of his life, he has to make sure he doesn't develop bed sores or UTI. If somebody's got a stroke and a tracheostomy, you have to make sure that he's able to breathe, eat, and swallow. So these are all the various challenges that people have. And it requires a whole teamwork of doctors, nurses, physiotherapists, occupational therapists, speech therapists, psychologists, dietitians, vocational trainers, social workers, and the team of doctors also includes who may be involved are neurologists, neurosurgeon, plastic surgeon, spine surgeon, urologist, physicians, respiratory, pediatrician, because these are patients who are going to require so many problems. They may develop so many problems and complications. So the conditions usually treated with rehabilitation are stroke, brain injury, and spinal cord injury, which account for almost 80 to 90%. The other things are neurodegenerative problems like Parkinson's, Alzheimer's, and various other neurological ataxias, and what Dr. Socrates said about HIV, neuropathies, and so many neuropathies also need post-operative care after major surgeries, and a whole gamut of pediatric problems. Now, I'm just going to touch now a little bit about when do you start rehabilitation? Do you send the patient straight from hospital, or do you send them home and say, okay, you come back after 3 months? So studies have documented that better outcomes are in patients who have early rehabilitation. Early meaning if a patient is admitted in hospital with an acute stroke, so he has a treatment for stroke in ICU, and then he comes down to the ward. And once he's down in the ward and ready for discharge, he goes straight to rehabilitation. You don't send the patient home and then bring them back to rehabilitation. So there are plenty of studies which have compared people who are discharged home and then come back. It becomes more expensive because they will develop complications. The outcomes are not very good. The long-term results of pain, spasticity are all not very good. So it is better to send them straight to rehabilitation if it is accessible. So this is the same with both spinal cord injury as well as brain injury and stroke. And complications like DVT, PE, pneumonia, UTI, sepsis, all of these things will be better if you mobilize them early. So to mobilize them early, for example, if you have to mobilize a person with a spinal cord injury, it is impossible to do that therapy at home with one physiotherapist. You need multiple people. You have to have a plan. You have to have the person has to be in a hospital setup. They may need psychological support. They may need occupational therapy. They need wheelchair skills. They need transfer skills. They need sitting skills. They need to learn about bladder bowel management. So all of these things, if they're not taken care of, they will develop all these complications. So, whether it is brain injury or stroke, the timing and the type of rehabilitation is very important. From acute to subacute, they have to transfer. So ideally, between 3 to 6 weeks, when the patient is physically, medically fit to leave the hospital, that is when you start rehab. So in Kaveri Hospital in Chennai, a person who comes with either a stroke or a brain injury will be transferred usually within the first 10 days. Even before they're ready to go home, we send them to rehab where they have tracheostomy care and other things. And it also reduces the cost for the patient. So early rehabilitation has many advantages because there are many studies which show that one of the common things is bed sores. The person lies in bed for more than 12 hours is a very high chance, 80% chance of developing a grade 1 bed sore. So there are lots of studies, lots of technology that has gone into designing bed sores, air beds, cushioned beds, air circulated, ventilated beds. So many other technologies have come. The next thing is a lot of stroke patients or brain injury patients need tracheostomy. So tracheostomy care is very important to avoid ventilator associated pneumonia. So if they are not on a ventilator for a long time, they probably will have a better outcome in terms of complications and sepsis. So what we tend to do is when we do the brain surgery, we wait for 24 to 48 hours and immediately do a tracheostomy. Sometimes in patients with high cervical spine injury, when I operate the spine at the same time, I do a tracheostomy at the same sitting. Because once you do tracheostomy, you actually shift them very quickly for rehabilitation. Pain is a major problem. 80% of people with any neurological damage will have some type of pain. Usually it can be either mechanical pain, it can be visceral pain, which is rare, but most likely is neuropathic pain. So this neuropathic pain is sometimes very, very difficult to treat. And they need various other modalities if they fail pharmacological treatment. So the first line is obviously medical management. But if they fail medical management, then we have a huge variety of things like a spinal cord stimulator, an intrasternal pump where you can directly deliver the medicine into the spine, dress lesionings, which is one of my favorite surgeries, which I do routinely, and selective rhizotomies, which we do more so for spasticity and in children. So I'm going to talk about all these advances which we do. So the spinal stimulation is like a pacemaker, which has a battery, and you go into the spinal cord and you stimulate the spinal cord, and that helps with pain. It can be used for chronic back pain. It can be used for failed back syndrome, but also it can be used for neuropathic pain, which is secondary to either cancer, stroke, or a spinal cord injury. There are also many systems for bladder and bowel irrigation. So bowel irrigation systems help with bowel management. So person with spinal cord injury, will not have control over bladder and bowel. So these people will need to be trained how to move their bowels. They can do a finger digital evacuation. They can use suppositories, but over the long period of time, some of these things don't work. So there are many systems which are available. Similarly, there are also stimulators, like how we have a stimulator for the spinal cord. There is also a stimulator for the bladder function. So this is again something that has been used. I do not have personal experience. There are very few cases done in India, but they have excellent results and it's quite expensive. These stimulators, they cost anything between 10 to 15 lakhs. And they need a trial phase and then I have a permanent phase, especially the bladder ones. The spinal cord stimulators, we do them routinely. Then comes to intrathecal pumps. So intrathecal pumps can either deliver baclofen, which is a muscle relaxant, or they can even deliver morphine or other drugs for pain management. In India, we are not yet licensed for morphine. We are licensed only for baclofen, but it can be used as a subsidiary. And there are special pumps which are available, which are battery operated and they can last, and is usually used for cancer pain currently in India. So intrathecal pump is like a little pouch, like a battery that you keep it in the pocket, and then it is tunneled into the spine. So it's one of my patients who had this surgery. We keep this pump and you can control how much of this should go from outside, how much the pump should deliver into the spinal cord, how much of baclofen needs to go in. So all this can be designed from outside and can be adjusted by the patient also. The next is selective dorsal rhizotomy. So this is a procedure where you identify which roots which cause the pain and you can selectively dissect them and you can remove them. So it's a very tedious, long procedure where you have to identify which are the roots, where is the pain coming from, and you can try to isolate them. This is used more for spasticity, and very commonly I use them in children with cerebral palsy. And neurotomies can be done, so you can identify which area or which dermatome and myotome where the pain is coming from, and you can identify those roots, and with the help of an neurophysiologists, which we have in our hospital, will be able to do selective rhizotomy. So the future is getting even more interesting. So we have a lot of technology now in rehabilitation, especially both upper limb and lower limb. And let me show you just a few. So over the years, in the last 5 decades, from having basic rehabilitation, which rehabilitation actually became popular and was started in London. And this was after the Second World War, when they had lots and lots of people with spine and brain injury, amputees, people with spine injury, paralyzed, and people with head injuries. And that is when rehabilitation became popular in the 1950s. And now we have advanced rehabilitation in terms of robotics, wearable technology, AI, gamified, rehab gadgets. We have exoskeletals and various other things, which we will touch upon briefly. So these advances are all to do with computers and with robotics. So you have the robotic assisted therapy. And the reason for robotic assisted therapy becoming more and more popular is because we have found that by repeated movements, by repeated activities, and that is why we say people that, if you want to be fit, you have to be doing regular exercise. You can't do exercise intermittently. So if you want to have a six pack, if you want to reduce your belly, you have to do regular exercise of those muscle groups. Same way, if you want to improve the power of a limb, if you want to improve the power of the legs or the arms, you have to do repeated movements. And sometimes the patients find robotic assisted more beneficial. Similarly, virtual reality, gamified, tele-rehabilitation, and other things. So this is something gamified. So for example, this person has a stroke and he wants to do hand exercises, and he has a computer there and there are games. They are similar to the Xbox that your children play with, or the Wi-Fi of Nintendo. So all these things, have been transferred into medical care. Then the next thing is what we have is we have functional electrical stimulation. So this is something that you can place electrodes, and as the patient is doing exercises, it synchronizes with that. So there's an electrical stimulus which stimulates the muscle group, and that's replicated into a functional use. And there are many devices both for upper limb and lower limb. And the principle is that the muscle is stimulated, the nerve is stimulated, the muscle is stretched, and the muscle relaxes. And this becomes an repeated activity. And there are lots of technology that has come in where you have functional electrical stimulation associated with either robotics or motorized machines. For example, you can see there in the picture, the person just keeps moving his hands or his legs through a machine, and at the same time the muscle is being stimulated. Then we have free hand systems where people who have amputees, either the upper limb or the lower limb, you have a free hand system where you have a pump, you have various electrodes along with functional electrical stimulation. You can actually activate a certain function. Exoskeletals is something now becoming very popular because the technology is improving. The materials with which we make these exoskeletals are becoming more lighter and durable. We are actually in a trial phase in Chennai with a company who have been devising exoskeletals, and we are actually going to try in one of our first few patients. So these are devices like you see Iron Man, or you see any of these characters who are wearing these jackets and they're flying around and walking. So very similar things. This was initially designed for the American military, but it has now come into use for the general public and for medical reasons. So there are different companies in the last 2 to 3 decades which have started to develop these exoskeletals, and for various reasons they can be done. So this requires excellent rehabilitation facility for you to wear this device and start walking. This is mostly used for young people with spinal cord injury. And there are so many robotic assisted machines that's come for hand function, for individual muscle groups. And also you can do a lot of robotic training for upper limb, which is gamified, and for the lower limb for the walking. And these are all machines which your patients can wear and they can do it. They're very expensive. And definitely in India, there are about 4 or 5 of these machines in different cities. So power assisted. Now coming to patients who are wheelchair bound for spinal cord injury, definitely they may not have complete function. They may not be able to walk, but they need a wheelchair for the rest of their life. So we know we have only seen standardized simple wheelchairs, but now there are very advanced wheelchairs, very lightweight wheelchairs. Recently, I was in a conference in Trichy last week, and I saw a German company who are importing now. The entire wheelchair is only 6.5 kg. So which is something that a patient can sit on it. He can drive up to a car. He can take that wheelchair, unfold it, and put it in his car, and he can do it by himself. So that is how technology has improved. And also we have standing wheelchairs where a person can actually stand for some time. Then we have various wheelchairs which are controlled by suppose a patient is quadriplegic, can't use his upper limbs as well. So the wheelchair can be mouth operated, sound operated, light operated. And I'm sure in the future with AI, there's going to be so many other things coming, especially with Elon Musk and his Neuralink. I think brain computer interface is also going to happen. And adaptive devices, now a spinal cord injury patient can easily drive with hand brakes, and it is also certified by the government. And I've seen patients who have come to see me from very far away, driving 100, 200 kilometers, paraplegics in a car because the car is modified. And so many vehicle modifications have come up. Household modifications are there, especially for elderly people. They cannot climb stairs. You can make a simple lift, a chair lift without a proper lift. And environmental control. So people who cannot have, use their hand function. So they may have an disability in their hand. So with the hand function is lost, they can use various other gadgets in order to do that. Voice control softwares are there, and different type of switches and buttons which can be used, and different types of ways in which they can operate computers, operate lights, operate the wheelchair is all present. So the technology is moving. Now coming to something even more advanced is neuromodulation. So the neuromodulation is basically electrical stimulus which stimulates certain parts of the neural system, either could be the brain, the spinal cord, or a peripheral nerve, which creates some function. So you have neural prostheses, you have the brain computer interface. So the neural prostheses are similar gadgets which have a connection through an EEG to the brain, and you can have a prosthesis which can function. It can be either an amputated leg or it could be an amputated upper limb. This is what I was talking about, the brain computer interface, where Elon Musk is trying to create something with the Neuralink, where you have a chip in the brain, and if you can't use your limbs, then the brain operates the function. So whatever you think can be operated, put into action. And so this is something that we are really looking forward to in the future, which bypasses the spinal cord, bypasses the peripheral nerve, and we are able to do certain activities. So this is a man who's sitting there thinking about, operating or taking a glass of milk or water to drink, and he's able to do that, but he cannot use his limbs. Then we have spinal cord stimulators or epidural stimulators. So this is, you keep epidural stimulators in the spine. We have done a case in Chennai as well. And this will allow person with paraplegia to be able to have some muscle function. So an epidural stimulator with an exoskeletal and with rehabilitation will be able to walk. So these are revolutionary things that are coming up. And probably in the next decade, these things will really have a big role to play, because, a paraplegic person does not have any hope. You cannot make them walk. You can give them rehabilitation. You can train them in their bladder function. You can train them in the bowel function. You can put them on a wheelchair, and they can do so many things on a wheelchair, but they cannot walk. Whereas these electrical stimulators which are coming up is probably going to benefit not everybody, but a certain group of patients with lower spine problems. And then we have also the brain stimulators, the deep brain stimulator called the DBS. So these are electrical electrodes that can go into the brain, into the thalamus and subthalamic nuclei, and they can cause various effects on the brain, pain management. It can be used in Parkinson's, in depression, in so many areas, which has become very used. Now, I want to just touch on a few very important things. Stem cell treatment in spinal cord injury. So, there's a big hype about this, but there's also hope. So we all know that, people are now using stem cell in various areas. PRP and stem cell is being used everywhere, from your joint pains to shoulder injection, knee injection, avascular necrosis of the hip joint, for skin regeneration, for hair growth, for so many things that we use these cells. And also the media in terms of spinal cord injury has given a very wrong impression about stem cell treatment. I'm talking here specifically about brain and spinal cord injury only. I'm not talking about all other conditions. So India, China, Korea are the most popular countries in the world for international people to travel to take these injections. Unfortunately, we don't have regulations. The Indian government does not allow. Even Superman, you probably all know Christopher Reeves. He was the longest living high quadriplegic. So he had a C3-4 injury. He died in about 9 years or 10 years. He has a very big foundation which does research called Christopher Reeves Foundation. But again, he never had any of these treatments, and he was a long surviving quadriplegic. So the national guidelines is that in India, stem cell treatment for spinal cord injury is banned. It is illegal and it should not be done. Stem cell therapies, there is a hope. There is potential for the future because there's a lot of research, a lot of ICMR projects which have been going on. There are some projects in CMC Vellore. There's some projects going on in Mumbai, Delhi, and many centers are doing a lot of research on rats and animals with some results. But the hype is that, oh, there is a cure, come and take injection. And people, sell property, pay a lot of money for not properly prepared stem cells, not properly prepared pluripotent cells, and they have spinal injections. And I've seen people who had incomplete injury becoming complete injury. So right now, it's a big psychological effect on the patient with the wrong hope. But the future holds good. Definitely, we will have. So I just want to conclude by saying that rehabilitation is a teamwork. You have to have the right patient. You have to have the right surgeon or physician who has done the procedure. You have to need a good team of therapists, and with advanced technology, rehabilitation has better outcome. So we at Chennai, we have a HAMSA Rehabilitation Center in Chennai, Vellore, as well as in Trichy. And I just wanted to show you, what a rehabilitation center has. So in Chennai, Rehabilitation Center is in Roypeta. And here we have a whole team of people who are, inpatient rehabilitation center, which requires, physiotherapists, nurses, doctors, peer counselors, occupational therapists, psychologists, dietitians, and also similarly for children. We need a lot of gadgets, download functions, weights, gadgets for children. These are all virtual reality, gamified things. These are the requirements of be able to push through the patient, because patients need to come for rehabilitation for several months. And sometimes they get very bored. They're not cooperating. And they don't want to do rehabilitation. So you have to keep motivating them because they feel that there is no, proper outcome at the end of their rehabilitation. So we have to keep motivating them. And that is exactly what we tend to do in this situation. Because they need recreational therapy, they need support of the family. The caregivers require support because caregivers also have to stay with them for several months. So unless you're able to do these things, you are not really able to achieve the right result. So many times we see doctors who send them and say go home and keep a physiotherapist and do therapy, but that is not sufficient. So these people require much more longer rehabilitation for several months. Some of our patients stay for 3 months to 6 months. So once again, I'd like to thank Dr. Rajesh Babu, IMA, and all the organizing team of the Coimbatore IMA for inviting me for this talk. Thank you so much.
Much for giving this opportunity. So I had a present experience Thank you very much.
Hi, no, I think this is a very good initiative. Please continue to do this. And I think, more participation. Maybe you can also join with these broadcast channels and broadcast this in other platforms that might reach out to more people. Thank you.
Okay. So,
Thank you.
Dr. Vikram sir is available? Dr. Vikram?
No, sir.
It's not there.
Sir is not available, sir.
Okay, thank you all. Good night.
Thank you.
sir.
Good night.
We thank the speakers of the day and all the participants who have joined today. And thank you all for joining the program. Thank you so much.